Hello and good evening, all. Hope you are having a very good day, and I'm happy to see some of you back here with us. This is our Stronger Together live event, online patient meeting, and we are starting off tonight with Dr. Gat Lavi from the US, actually. Hi, Dr. Lavi. How are you feeling tonight?
Hi, excellent. Good to be with you.
Happy to have you here as well. And well, just let us know that you can hear us as well, so we can make sure that all is working. I am your host as always. This is Caroline speaking, and also just let me remind you how it's going to work today. Okay, I will explain you some details, and we will start with Dr. Levy's presentation. But before that, let me just remind you that the Stronger Together initiative, those online events that we are having every single day from Monday to Friday, 2 times a day even, this has been brought to you thanks to our partners and ambassadors, and some of them you already get a chance to know, and those are right here. You can see them on the screen. So huge thanks to them, because without them, of course, our Stronger Together initiative wouldn't be possible. And we definitely want to make sure that you will meet top experts and will definitely have a chance to ask so many different questions and meet so many different experts from various countries as well. And today, of course, we have another special guest. This time, as I've already mentioned, it's Dr. Gat Lavi from who is medical director and founder of New England Fertility, which is located in Stamford in Connecticut. So hello to US, and happy to have you, as I mentioned, happy to have you here. And of course, Dr. Lavi will be explaining egg, embryo, and sperm donation in the USA, availability, legal aspects, and costs. So remember that he will start with his presentation, as I've mentioned. Then we will go for most common questions that we receive and on the topic, and of course right after that it will be your time to ask your questions. All you need to do is just simply put it in the chat section, that so that Dr. Levy can answer them for you. And well, this is it from me at this point. As I mentioned, Dr. Levy, good to have you here. Are you ready to begin with the presentation?
Thank you, Caroline, for the introduction and for setting this up. It's a little technical for me, but hopefully we'll get through it.
I'm sure we will.
So, regards to everyone from the US, from Connecticut. These are crazy times for all of us, and I will be discussing that portion towards the end. But I think, these times we're sort of used to connecting through Zoom or video conferencing. Of course, it's not ever as good as face to face, but at the very least, in a way of an introduction and at least in educating you on the topic, I think it will be good. Um, of course, this is just an overview. Of course, if you have specific questions, I'm always more than happy to arrange for a one-on-one call. So the topic that I'll be discussing is mostly egg donation. I'll talk about, of course, the foundation of all of this, which is in vitro fertilization. I'll talk about how that process works. I'll talk about the US, how we do it, and we'll talk quite a bit about the egg donors themselves and who they are, how we find them, how we test them, and how we match them to the recipients. And at the end, of course, I'll touch about the requirements to do it in the US, and at the end we'll talk about the COVID-19, which is on everyone's mind. So I'll explain a little bit how we manage, how we deal with that. So essentially, this is the list of topics I was going to talk to you about, starting with, the egg donation, who needs a donor, who are the donors, how I find a donor, and how I do it. Specifically for the US, why there is an advantage in doing it in the US. And I'll explain. I think we have better donor. I'll explain that. You have more information on the donor. The process is somewhat different than the way it's done in Europe. And the legal issues are very simple compared to other countries. And finally, with COVID, we'll talk about, is it safe to do it now? How is it different now? And of course, always the big question is about travel during the COVID epidemic. And just to, I don't think that needs to be reminded, but basically our goal is to have a healthy baby, one healthy baby, and have a pregnancy that is uncomplicated, it's simple. Because I know that many of you, most of you, I assume, have had a long journey before coming to egg donation. And I think finally at this point, the idea is to try and keep it as simple and as successful as possible, and to get success as quickly as possible. And to do that, we have put together a team. Our clinic specializes in egg donation and in surrogacy. So we have a team that basically is geared towards that. And it includes clinical people, laboratory people, legal, and of course, the donors, the parents. So we all have to work together in order to achieve that. So it's certainly not one person, it's certainly not just me. I have my whole team that supports me to give basically not just the best care, but also the most personal and the most positive experience that we can. Just a few words about IVF, because all that I'm going to be discussing will not be possible without the in vitro fertilization, also known as IVF, and all the improvements that have been made in IVF in the last decades. So IVF is a relatively young field. First case of IVF was done in London at Bourne Hall by Dr. Steptoe and Edwards that are here in the picture. And the first baby was Louise Brown, who is here in this picture when she was just born, and this is about almost 10 years ago. So, and we've come a long way. The first one was in July of 78. The second baby was in January of 79. And sure enough, last year we've sort of counted about 9 million IVF babies. So we've come a long way in a relatively short time, and we've made some significant progress. Of course, it's not perfect. Of course, there's always room for improvement. But with the improvement in the technology, with a higher success rate, we can apply IVF to areas that were not used in the past. And we don't consider IVF as an experimental procedure. Actually, it's considered to be a mainstream procedure. This graph basically shows you that what happened with the improved technology, the blue line that goes down shows you that over the years, we've cut down on the number of embryos that we put back in, and we've gotten a significantly improved success rates. And that's important because when we talk about the embryo transfer, when we put the embryo back into the uterus, the key there is to, of course, pick the right embryo. In this case, pick one embryo that has about 80% chance of success. So we don't need anymore to transfer multiple embryos to get good success. And by doing that, we basically lower the risk associated with twins, triplets, and so forth. And I want to very quickly review the IVF process, and basically because that improvement in the different steps of the IVF process is what leads us to where we are today. So, we have the ovarian stimulation where the woman would get medications to increase her egg production. We have the egg retrieval where the eggs are harvested. We have the fertilization and growing of the embryos and the embryo transfer. So all these things have actually undergone significant changes over the years. So for example, we have better drugs now that are not only more effective, but also much safer than they used to be. So that allows us then to, especially in the case of egg donors, allows us to use those drugs on young, healthy women who themselves are not interested in getting pregnant. And again, I'll get back to this later. When we use donors, our number one goal is to make it as safe as possible for the donors. The fact that we can grow the embryos in the laboratory for 5 or 6 days, basically until what's called the blastocyst, which is the last stage in the development before the embryos have to be placed back into the uterus, also had a huge impact on success. Because just by watching the embryos grow, you can very quickly tell the difference between embryos that are viable and embryos that are not so viable. So it's easier to pick the embryo that will give you success. The sperm injection, or what's called ICSI, is a way of fertilizing the egg by inserting a single sperm into each egg. That again has been a big step in IVF because it allows us to use sperm that is not always of the best quality and still get the same results for fertilization and embryo development. Embryo freezing, another area that has gone tremendous changes in the last 5 or 6 years, essentially allows us to freeze the embryo at any given point and then expect the embryo to retain its viability when it's thawed. Whether it's a week later, a month later, a year later, the embryos are exactly the same when they're thawed as they were when they were frozen. And I'll show you in a minute how that actually plays into our IVF process. Another big development is the fact that we can do genetic testing on embryos. And this graph, these bars shows that there is, basically a significant improvement, almost double the success in embryos that have been genetically screened compared to embryos that have not been screened. And essentially, the genetics screening of embryos has become very standard for us. Initially, we did it on women who are older, where we expect a higher percentage of abnormal embryos, sometimes no abnormal embryos. And in the last few years, we've also added our donors to this test because we find that even in these women who are young, healthy, highly selected, we still get about 30 or 40% of their embryos that are abnormal. That compares to a woman who's 40, who maybe 90% or more of her embryos are abnormal. So again, even with donors, there's an advantage because it allows you then to pick one embryo and get 80% success. So IVF is in place, and now we basically talk about different variations on the theme. And when we talk about the IVF process, we always talk about the components, right? The sperm, the eggs, and the uterus. And I always tell my patients that, if you come into this process with an open mind and you're willing to use all that we have available, there's a very, very high probability that you'll be successful. And that means, using a sperm donor if necessary, or your partner's sperm, using an egg donor or your own eggs, or using a surrogate or your own uterus. And of course, for every person, there is the way that will actually make them successful. And it depends on your history, and it depends on what you've done previously. But that's sort of part of the discussion that happens when we first meet. So by basically having that option of the egg donation and surrogacy and sperm donation as well, we can basically do what we've always wanted to do. And this is actually what brought me into this field of medicine, is the fact that we can help more people to build families. Whether you're single, when you're married, whether you're heterosexual, or whether you're homosexual, men, women, basically everyone in some way or another can take advantage of this technology. So egg donation alone, we usually do for essentially either older women or women that have poor egg quality. And I'll touch on that in a minute. Surrogacy is indicated in cases where the uterus is abnormal or absent, or a woman has medical issues that preclude her from carrying a pregnancy, and sometimes even just emotional issues. And we consider those to be perfectly legitimate because some women are afraid of being pregnant, had a bad experience, and feel more comfortable that someone else carry their baby. And of course, the combination of egg donation and surrogacy is required for same-sex male couples. So they would use their sperm, one or both partners, and then they'll have an egg donor and a surrogate. Even for same-sex female couples, there are certain variations that work. Single men and single women. So in other words, we've widened significantly the field and allowing more and more people to participate in this new technology. And just a quick overview of how we do IVF, how this process is done. So like I said, we need the sperm, we need the eggs, and we need the uterus, and the sperm can be from a donor, from a partner, the eggs can be from a donor, from a partner, and the uterus can be from a surrogate or from the female partner. So once we've determined for the individual couple, individual client, what is their path, what their journey would look like, then we focus on the detail. And the diagram here is basically to show you how we do IVF. This is true for IVF in general. This is true for IVF with egg donation and IVF with surrogacy. Essentially, as you can see here, we do it in two parts. First part is the embryo creation. The embryo creation, we create the embryos, we grow them, we do the genetic testing, and then at the end of this part, we freeze all our embryos. So this first part takes about a month. In the case of egg donation, of course, you need to have found a donor, and we need to have the sperm, whether it's donor sperm or partner sperm. The donor would typically go on medication, on fertility drugs for about 2 weeks. During that time, she gets checked. We make sure that she's comfortable, make sure she has enough eggs. And at the end of 2 weeks, the eggs are ready to be harvested. The donor will go through what's called the egg retrieval, a very simple 10-minute procedure we do in the office with a little bit of sedation. And then we have the eggs, and basically the donor has completed her part and stops all her medication. So we have the eggs, we add the sperm, we create embryos, we grow the embryos, as I showed you, to the blastocyst stage, and then we do the genetic testing. The genetic testing also goes by the acronym of PGS, pre-implantation genetic screening. And in this process, we essentially count the chromosomes to make sure that the embryo has 46 chromosomes, which is the normal number. So we can eliminate embryos that have extra chromosome, like Down syndrome, for example, or missing chromosome, like Turner syndrome, but many other things. So those abnormal embryos are basically what usually leads to lack of success or to a miscarriage. In order to do the genetic testing, we remove a few cells from each embryo without damaging the embryos, very gently, and then send the cells to be tested and immediately freeze the embryo. So the embryos are frozen. About a week later, we get the report, and the report basically tells us normal embryo, abnormal embryo, male or female. And I'll explain later that, in the US, there's no issue with picking the gender if you have the embryos of that right gender. So that's step number one. Step number two is the embryo transfer. In this case, actually is depicted as a surrogate, but of course it can be the female partner, the patient. In order to prepare for the embryo transfer, we have different protocols, different types of preparation. What I prefer more and more, if the woman has normal cycle, natural normal cycles, We try to use that as much as possible because it's easier and because it's highly successful. If they don't, and many women who require an egg donor don't have normal cycles, we essentially create a natural cycle just by using the proper hormones, the estrogen and progesterone. So again, the second part is about a month. It takes about 3 weeks from the beginning of the cycle until we can transfer the embryo. During that time, the woman, of course, will be monitored, prepared, and of course, that's very relevant if you're doing, if you live in the UK or you live in Europe and you're having the transfer done here. And as I said, I mean, we typically transfer a single embryo. We have 75, 80% success with one embryo and no twins. And we have about 90+% success of having at least one baby with two embryos, but the rate of twinning is extremely high. We don't have time to discuss this right now, but for those people who really, really want to have twins and are aware of the risk, that's something that can be discussed. And of course, we need to make sure that the person who carries, whether it's you or a surrogate, is able to carry twin based on their history and so on. But typically, the standard is to transfer a single embryo. As far as the sperm, if we use partner sperm, of course, we need to do a semen analysis. We usually freeze the sperm, so we use frozen sperm for the fertilization, again with no impact on the success. And before we use the sperm, we do some genetic testing, what we call carrier screening, to make sure that we know if you are a carrier of any kind of genetic conditions. Those are recessive conditions, and if you are a carrier, you just need to make sure that the egg donor in this case is not a carrier of the same genes. What's listed there is that FDA testing is basically infectious disease testing that are standard, and just a little bit more extensive if you're using a surrogate. But that's sort of the standard preparation of the sperm. If we need to use a donor sperm, we would utilize one of the commercial sperm banks. We work with 3 of the largest sperm banks in the US, and we can guide you through the process of how to select the donors. The donors of the sperm banks also go basically through the same screening process that we use for our egg donors. So you can be assured that you're not going to have any genetic issues, any infectious disease issues, and so forth. So now we'll talk more specifically about egg donation. And the indication, as I briefly mentioned before, is basically we have two large categories. One is what we call poor egg quality, and that could usually relate it to age. So we all know that for women, the reproductive window is much narrower than it is in men. So by the time women get to their late 30s, early 40s, their fertility declines dramatically. So most of the patients who require an egg donor are those who are too old to have good eggs, or have tried IVF without success, have done IVF and had genetically abnormal embryos. So I would say that's sort of the largest category. And then there are cases where a woman carries certain genetic conditions that make it basically impossible to have a normal child. And some cases where there's been environmental exposures that affected the egg quality, radiation, chemicals, and so forth. Thankfully, we don't see too many of those. And then, as I mentioned earlier, same-sex couples, single men, require an egg donor to have their biological child. So it will be their sperm and an egg donor and a carrier to hold the pregnancy. So, of course, the question that everyone has and that he really wants to know is, who are these women? How much information can we get about them? How do we test them? How do we know exactly who they are? And I will touch it later on about the U.S. how that differs from Europe. But essentially, in the U.S., you're privy to any and all information that we have about your donor. So what I listed here is just the criteria to enter, to apply to the program. So we only take young women under the age of 30. They have to be healthy, non-smokers, and no significant family history. We also don't accept any donor who's adopted because we cannot have that family history. So that's a very, very important consideration. And then once they got in the door, then we do the screening. And I listed here the different category. The medical screening, where we review the medical history and the medical records. We do a lot of psychological screening. We do an interview with the donor in person with a counselor, and then we do a written personality assessment test. We do even more genetic testing. We have a geneticist that the donor works with, creates a family tree, and basically does the full panel of what we call carriers testing or testing for recessive conditions. This is the area of the genetics have actually also improved dramatically over the years. Whereas at the beginning, we were only testing for a few genes, 6, then 8, then 20. Now we're up to almost 300, which is good in the sense that it gives you a much better idea if the donor is a carrier. Keep in mind that when you test for so many genes, we find that most of our people who are tested come back positive for something. And really the importance of doing the carrier screening is to make sure that when you match with the donor, you're not carrying the same condition. So we will review with you your carrier screening, and we'll review as well the donor screening and make sure that it's compatible. And of course, it goes without saying that we do very, very extensive infectious disease testing. That part of the process in the US is controlled, supervised by the government, by the FDA. Hepatitis, HIV, CMV, syphilis, chlamydia, and so forth. And with that, that's a lot of information. And with that information, we create what we call the donor profile. And the donor profile is basically a compilation of all the information that we have about herself, about her family, what she does, what she likes, what books she reads, and pictures. We usually have multiple pictures of the donor. So when you put it all together, you basically can get a good idea of who this person is, what she's like, what she looks like. For many people, actually making the decision to use an egg donor is a very big step, a very big emotional step. And some people never get past that. But you know, you have to be comfortable not only with the fact that you'll be using a donor, in other words, you're not going to be using your own genetics. But once you've made that decision, once you've crossed that hurdle, the next is to find a donor that meets your requirement, whatever your requirements are. Some people have a long list of requirements. Some people don't care very much as long as the donor is healthy. Most people are somewhere in between. So we use those profiles to help you find a match, to help you find the right donor, whether it's the physical characteristics, whether it's the ethnic background, education, and so forth. The other thing that we discuss, and again match your request, is whether you want to have any connection, any contact with the donor. Very different than where the conditions in Europe. In the US, there's no restriction on having a connection with the donor. So for some couples, it's important to actually establish that connection. Some prefer to have a relationship, meet in person, meet online, speak on the phone, exchange emails. Everyone has their own idea of what that means. Some people say, well, you know, we don't really want to meet the donor, but we want that option for the child. So the child basically reaches an age where they say, that they want to know who their egg donor was, then, we can arrange that the donor will leave us with contact information that the child can use. So again, what this basically proves is this is a very, very individual process. Everyone has their own story. Everybody brings their own baggage, and everybody has a different path. And whatever you do, however you do it, is okay. And for me, it's just important to get to know you a little bit better and know, essentially what you want to do and what you're comfortable with. I have here the viewing the donor database. I think actually I put a link here to our donor database, but it's not working. But you're more than welcome if you want to contact us later. Is to have access to the database, and then that will give you a real idea of what the donors look like. Essentially, look at their profiles, look at their pictures, and I think that's for many people is sort of dipping their toes in the water, just allowing you to make that first step. And some people take no time to pick a donor, and some people take forever. For most people, it's about a 1 to 2 month process. So we help you create your list of requirements, and we help you sort through the database and find a donor. We have over 100 donors in our own database, but you're not limited to our database. There's plenty of others, so we can go outside of the clinic. There's many agencies that actually recruit egg donors. What I can assure you from my perspective, that every donor that we work with, whether it's one of ours or whether it's a donor from the outside, will have all those different screening tests that we implement for our own donors. So again, I mean, it's just a matter of how far out you need to go. And often it's a financial decision as well to find a donor that you require. What I described, and that diagram that I showed you, is basically the standard process that we do here. So you look through the database, you find your donor, we have the sperm, and then we set up the donor for treatment. She takes the medications, usually produces approximately 20 eggs, and all those eggs are yours. That's the standard process. However, because of the cost mostly, we offer other options. So for example, an option where you use, instead of taking all the eggs, you only get half of the eggs. You split it with another couple or with us. And then there's a third option where we have eggs that have already been frozen. These are donors that have already been through the process. And those eggs actually go in groups of 6. So most people actually prefer the other options because of cost. But some people actually also feel not so comfortable having so many eggs and so many embryos. So for example, if your plan for your family is to have 1 child only, maybe you don't need 20 eggs. Maybe if split cycle is enough. So you need to review that information with us. You need to go over the cost with us. I can tell you essentially, as far as numbers are concerned, about 20 eggs from a full cycle, which translate into about 6, 7, or 8 genetically normal embryos, each one about 80% success. With a split cycle, it's about half of that. It's 3 or 4 embryos. And with 6 eggs, it's usually 1 or 2. So again, a discussion that we have at length before you make your final decision. So this is the IVF process the way we do it. It's going to be the same, no different, whether you live in Connecticut or you live in California or you live in London. We do it the same way. The process in the US offers, I would think, many advantages. Just having worked in other places, having worked in Europe, having worked in the Middle East, India, Thailand, Nepal, the process in the US is different and offers many advantages. So as far as the process itself, uh, as I said, we have a very high success with transfer of a single embryo. So you don't have to risk having twins in order to increase the odds if you don't really want to have twins. And the reason we have this high success is it can be attributed to those things that I listed here. The blastocyst culture, the embryo freezing, the PGS testing, and so forth. And this is something that generally, as far as I know, is not done in most other countries. The other advantage of the US is that the egg donation is legal. It's legal in all states, and it's very easy. So, I mean, we advise that you create a legal contract with the egg donor, but it's not required. We only require it in cases where we use what we call a known donor, but not when you use an anonymous donor. As far as the egg donors, I mentioned already that you get unlimited information about the donor. So you look at the profile and you have 20 pages of information. And if that's not enough, we're happy to go back to the donor and get more information. We feel that the donors here are, at least compared to some countries, better health, better standard of living, better eggs, and better success. What I also mean by high quality donors is that we do extensive screening. So you don't have to worry about any of those things that we eliminate by doing the screening. The process is done at our clinic, and I think this slide is a little bit out of place, but we're in Connecticut in Stamford. The town is called Stamford. We're about halfway between New York City and New Haven. We're about one hour north of New York City. I started the clinic in '91, so it's been many years. And over the years, what started as a general fertility clinic has become now basically a clinic where we do mostly focus on egg donation and surrogacy. Again, it's IVF, but it basically requires a certain infrastructure, a certain knowledge. So it's a variant of IVF that we specialize in. My vision, my goal when I started the clinic after having trained in a university at Yale is to create a more private, personal, comfortable environment for patients. So we still are able to provide state-of-the-art technology, but do it in a more personalized environment. So the way we basically, if you remember the diagram I showed you earlier, how do we do it if you live in the UK or in Europe? So basically, as I said, we need the sperm and we need the eggs. We'll help you find the egg donor, and then we'll help you arrange for the sperm to be shipped here. If you're using a sperm donor, we can help you find a donor from an American sperm bank. But if you want to use your own sperm, my preference always is that you come here to give the sample, but it's not required. I mean, if you feel more comfortable, especially these days, you can basically go to a clinic in London. We can connect you with, freeze your sperm, and then it will be shipped to us. As far as the embryo transfer, if you're going to be carrying the pregnancy, it's basically, as I described, takes about a month to be ready. Most of it is essentially just tracking your cycle, tracking your hormones, and making sure your uterus is developing normally. So we can do most of that, or you can do most of it locally. We'll connect you with one of the clinics that we work with. And then that way we connect with them or we communicate with them. And that way you only need to spend definitely less than a week, usually 4 or 5 days in the US. Come, a day or two before the transfer, just get yourself acclimated. I usually like to see you here in the clinic the day before, do an ultrasound myself, just be comfortable that everything is good before we thaw the embryos. Then you have the procedure, and then you rest for the day, and then the next day or the day after you can go home. So we try to make the process simple and easy for everyone. And I said we'll talk a little bit about the COVID and how that's affecting us. And basically, there's sort of divide this into two parts. The risk to the baby and the risk to the pregnant woman. What we know is we basically only have, a little bit of information. We have a lot of information that has come from China, Italy, and unfortunately now the US. And we have actually created a network where we exchange information and we share information. So we had a call last week, for example, with doctors from Wuhan in China and doctors from Italy and doctors from the US, basically everyone sort of giving us their experience and their thoughts of how to proceed safely. So what we know so far, we know that basically if a woman contracts coronavirus during pregnancy, the disease is no different whether she's pregnant or not. So it's no worse in pregnancy than it is in a non-pregnant woman. So that's important to know because some diseases are actually made much worse by pregnancy. So that was very reassuring. The question that is still not completely answered is how would affect the baby. So if a woman contracts the coronavirus during pregnancy, what is the impact on the baby? The information we have, again, most of it is coming from China just because they were first, is mostly from the third trimester of pregnancy. Because again, the women who are early pregnancy haven't delivered yet. But those women who are in the third trimester of pregnancy, basically, I think they were able to show with some degree of confidence that there is no what's called vertical transmission of the virus. In other words, when a pregnant woman contracts corona, the virus doesn't cross the placenta and doesn't infect the baby. And that's different, for example, than Zika, and it's similar to the regular flu. And that's good, that's reassuring. What we do know also that in the first trimester of pregnancy, any disease, any febrile disease, where your temperature goes up, can put you at a higher risk for miscarriage, and that appears to be true for COVID, the same as is true for other febrile illnesses. So we, of course, treat this virus with respect. And, for a while, we stopped doing cases at all. Our clinic was not closed, but we were not doing any new cases. And as of this week, after consulting with other clinics, other doctors, I've put together some protocols that I feel allow us to restart slowly and do it very safely, and do it safely for our staff and safely for our patients. So, we talk to patients, we have the protocols in place, we have a consent that we ask you to sign. Of course, in your case, it also involves travel. But what actually is happening now that people actually are separating these two parts of the IVF process. So create the embryos, have them frozen, and then they figure that they will, once things lighten up a little bit, when things get better, then we can schedule the embryo transfer. So we talk about travel. We've actually also created a kit that we've sent people who travel into the clinic with a mask and other protective equipment to make sure that they feel comfortable with it. And then we talk about what to do during pregnancy. Again, not really very much other than normally, but be a little bit more careful as far as exposure, protecting yourself, and so on. So before I start answering your questions, I just basically wanted to give you sort of the flow chart or the step by step if you want to move forward. So as I said, what I just said was what I just talked about is sort of an outline, just giving you the information. It's really, really important to have an appointment and talk about your particular case with me, because I said every case is different. Every person has different requirements. Every couple has a different path. So once we've decided to move forward, we often move in parallel. We arrange for the sperm to be collected and shipped, and we start looking for the egg donor. And once we have the sperm and the donor, we can make the embryos. So we make them, test them, and freeze them. And then at some point, when you're ready, we can schedule the embryo transfer. Again, I didn't go into great details, but basically, I will review your records, see if you've been tested before, been evaluated before. If not, we complete the evaluation also remotely. And then we decide on the protocol to prepare and schedule the cycle and the travel and so forth. So thank you for your attention. We call this a journey, and really is a journey. And I wish all of you luck.
Perfect.
And I'm more than happy to answer your questions.
Perfect. Dr. Levy, thank you so much for your presentation. Very interesting indeed to find out all of those possibilities that are available in the US. Of course, it's definitely different than Europe, in Europe. So thanks so much for explaining this. And well, right now we will go for the most common questions. Some of them you already kind of covered. However, if you could add a few things to this would be great. And then we will go straight away to your questions. So let's begin with the very first one. So what is the maximum age of egg recipient in the US? You have mentioned this, but if you could just give us a
Yes.
take-home message.
So basically, again, because the egg donation is legal in the US, and we don't have any restrictions on age. And what that means, it sort of puts the burden on me, on us, to basically determine what is the maximum age. And I personally, and I think I sort of feel even more strongly about that as I age, that the age is just a number. I think we have to look at the person, the couple, and decide individually if they're healthy enough to have a child. And I'm of the opinion that you talk about it, you explain it, and basically if that's what you decide to do, I don't have any ethical, moral issues with that. Of course, you need to take into consideration that if you're in your 60s and you have a baby, there's a good chance that you may not be around when the baby or the child gets older, and you have to make arrangements for that. But okay. I don't feel that it's my place to tell anyone, young or old, whether they can have a child.
All right, understood perfectly. Thank you so much for answering this question. And let's go to the next one. So what are the legal aspects and availability of egg donation in the US? Again, if you could add something to it.
Well, as I said, there's no real legal issue. So essentially, when you pick a donor, these donors have already been through an evaluation. We've already asked them, how they feel about donating their eggs. And for example, I just spoke to a couple today who picked a donor, and we actually matched them with this donor because she basically only agreed to donate to married heterosexual couples. That was her preference.
Okay.
And of course, we respect their wishes. But there's so essentially in this case there will be some contract between the donor and the recipients that will state that there was agreement. But as long as everyone has their position, and like, as I said, I advised people to have a contract, even if it's an anonymous donor, just to protect yourself.
Okay. Perfect. Thank you so much again. And let's go. So, which donor races are available in the US?
Well, you see, one of the things about the US is, especially in our area here on the East
Mm-hmm.
Coast, that there's a tremendous variation. There's a lot of different people from different places. So, a lot of diversity. We have European donors and we have African American donors. We have many Latino donors. We have Chinese donors. We just connected with the Japanese agency. So essentially, we have that advantage, the famous melting pot. But I think that's happening all over the world now, and definitely in Europe, which means that whatever donor you have in mind, we will find it. It may take a little bit longer. So there are certain ethnic groups,
Mm-hmm.
that are more difficult, like
Of course.
Chinese donors, for example, are more difficult, Jewish donors, and so forth. But ultimately, you have to decide, and we'll help you find what you're looking for.
Okay. Fantastic. Thank you so much again. Next question is, what is the average cost of egg donation program cycle in the US, including all donor costs, medication, egg retrieval and compensation, ICSI, blastocyst culture, embryo transfer? Could you provide us some details?
Well, I can't give you the exact cost.
Mm-hmm.
Actually, if anyone is interested, we can definitely send you the breakdown of the cost. I can just tell you that one of the reasons that for sure that egg donation in the U.S. is more expensive than in Europe. One of the reasons is that the donors require more money, more compensation.
Mm-hmm. Yes.
We pay our donors minimum $8,000 to go through the process to donate their eggs. But the donors basically can essentially name their own price, and as long as they find someone who's willing to pay. So some donors that are considered more high-level donors, difficult to find ethnic groups, highly educated, and so forth, sometimes ask for more money. So we try. For me, it's always been about making it fair, and making sure the donor is compensated enough. We really don't look at it as you buying the eggs. We basically pay her for her effort and for the fact that she's willing to do it. Uh, so we can send you a very detailed list of fees for the different parts, as Carolyn said, of this process.
Yes, perfect. Thank you so much. And yes, if you would like to get in touch with the team and Dr. Lavi, of course, it's possible. You can also use this website. I'm sending this to you right now. Once you click on there, there is an option, ask your question, and those questions requests will be sent directly to the team. They will be definitely able to get in touch with you and let you know about the detailed prices, etc. Okay. Thank you. And let's go to the next one. So, do you prefer fresh, synchronized, or frozen egg donation cycles? What's the difference in terms of success rates?
So again, what I showed is the diagram of how we do IVF. And this is true for egg donation. This is true for regular IVF. This is true for surrogacy. And a few years ago, we've basically switched from doing fresh cycles to doing frozen cycles. The reason we do that in general is because that allows us basically to focus on one hand and basically maximizes the number and the quality of the eggs that we get. And on the other hand, to basically optimize, maximize the development of the uterus to get best success. Now, so we always felt that was the right way to go. However, the problem was that the freezing technology wasn't good enough. So that's essentially what held things back. We used to do synchronized cycles. To do that, you basically need to synchronize your cycle, so with the egg donor cycle. It's not so difficult to do, and it was working quite well, but not as good as it is now. And again, the fact that we can freeze the embryos allows us to do the genetic testing, which is important, I think very important. Allows us to basically focus on your end and create the best uterus, and also makes it much more convenient. Because once the embryos are frozen, they can stay frozen for a week, a month, or 6 months without any change in quality and success. So that makes the whole process a lot more convenient.
Perfect. Again, thank you so much for answering this question. And do you recommend using PGS, PGT embryo diagnosis along with egg donation cycles?
As I said, I definitely recommend PGS. And the reason I recommend PGS because simply for the reason that we find that about 30 or 40% of embryos that come from donors are genetically abnormal.
Mm-hmm.
So by doing the PGS, it makes it easier to pick the one embryo that will give you the high success immediately. So that's the reason that we've incorporated PGS, PGS technology. So that's a topic for another talk, but
Mm-hmm.
has improved dramatically. We do the PGS now on day 5 embryos and not day 3, the way it was done in the past. And we use a new technology. It's called NGS that is highly, highly accurate. So we trust the results completely.
Perfect. Fantastic. Thank you so much again. And so you already have said it is possible, right? So gender selection is also possible.
Yes.
Perfect.
So yeah, we've been doing gender selection for a while. In fact, we have people come to us just to do IVF for gender selection. They have 2, 3 children of the same gender, and they want to do what we call family balancing. So that's allowed, and it's fairly common and standard. The thing about gender selection, of course, the way we do it is we fertilize all the eggs and then check to see what we end up with and make a decision based on that. We still don't have a good way to affect the ratio of male and female, because as I'm sure that you all know, that the gender is determined by the sperm. So
Mm-hmm.
this half of the sperm is male and half is female, and really is a matter of who gets to the egg first. So we still don't have a way to separate the male and female sperm. So there are situations, somebody comes in and wants to have a boy, and then somehow they end up with only girl embryos. So that's something you have to take into consideration. But most people that come to egg donation don't look at that as their first goal. They basically, if they have embryos of both genders and they have a preference, why not?
Okay. Thank you again for that. And what is the time frame of egg donation program? If patient is traveling from Europe, number of visits, length of stay.
So again, I mentioned that, and we try to make it simple and easy, and we try to people who are traveling in, we try to minimize the amount of time that they need to spend here. Of course, you're welcome to spend the whole cycle here, but for most people, I mean, there is a strong incentive to minimize the number of trips and the number of the length of stay. So we take advantage of the fact that we have some clinics that we're partnered with in London and in other places in Europe, where you can go and basically do your evaluation and you can do your prep. So we will determine the protocol, we will connect with the doctor, and then you can spend as much, you basically maximize the time at home and come here just for just for the embryo transfer, as I said, for 4 or 5 days.
Mm-hmm. Okay. Again, thank you so much for answering this question. How is an embryo donation in the US? Legal aspects, cost, and availability?
Well, the availability is not a problem really. As I said, I mean, between the different agencies, you have many thousands of donors to pick from. As far as the cost, as I said, the costs are definitely higher than they are in Europe. The cost mostly of the donors varies. So depending on how far out you need to go to find your donor, which agency you have to use, how much the donor is asking. So that part is variable. Not so much with us. We pretty much feel that, the donors essentially get paid just about the same amount. But if you're looking, for example, for Chinese donors, it could be twice as much as it is for a Caucasian donor. So there is a variation like that. And the legal aspects I already mentioned, it's legal in all states. There's no problem. It's always good to consider having a contract with the donor, whether she's what we call a known donor or an anonymous donor. But there's no legal issues really other than that. Not now and not in the future.
Okay, thank you so much again for that. And this will be our last question when it comes to those most common ones, and then we will go for your questions. So how is the sperm donation in the US? Anonymity, availability, and costs.
So the sperm donation is always anonymous, at least with the sperm banks that we work with. There are about 3 or 4 large sperm banks in the US. Those are the only ones we work with. They're all reputable. They've all been around a long time. We've had a lot of experience with them. And all of them have a large variety of donors. You can very easily go on their website. I can mention a few names. For example, there's a bank called California Cryobank, CCB. It's the ones that we work with the most. They have offices on the East Coast and the West Coast. They have many donors. They do a great job at screening the donors. And they also do a good job as far as trying to find a donor that meets your requirements. So the donors basically, the laws in the US for sperm donations are such that the donor has to go through screening, including HIV and all the infectious disease testing. And then the samples are frozen, and they're frozen for 6 months. And then they have to bring the donor back, rescreen them, retest them before the samples are released. So that's actually a rule from a federal rule. So no matter where the sperm bank is, they have to abide by this rule. The donors usually donate a few times. They create, multiple samples. And generally for IVF, we require 1 or 2 samples to be purchased. As I said, the donors in the US are essentially anonymous. Their anonymity is more so with sperm donors than it is with egg donors. So mostly with sperm donors, you won't be able to see pictures, but you still get a very extensive profile.
Okay, perfect. Thank you so much for answering all those questions, most common ones, but of course now it is your time for your questions. So let's get to them. We have lots of questions ready. So let me go for the very first one. Okay, you're showing 0% chance of twins with simple single embryo transfer, but my understanding is that just by doing through the IVF process, I think because of ICSI, there is some increased chance of identical twins. Anything you could add?
Yes, you're right. It may, the chance is not 0. But what we're talking about when we transfer a single embryo is that there's a very extremely low chance of twins, which is way less than 1%. And when you have twins with a single embryo transfer, what you have is identical twins. It's an embryo that splits. It happens, again, rarely. It's not so much of the ICSI because the ICSI just introduces the sperm into the egg. But for some reason, the embryo can split. Usually happens after the transfer. after the embryo has already been placed in the uterus, and that way you can end up with identical twins. But as I said, because the incidence is so low, we don't consider that to be a significant risk.
All right. Perfect. Thank you for your question as well as your you answering this too and explaining the details. We have a bit of a longer question, so let me get to it straight away. I've heard there's a lot of variation in how PGS is done, looking for repeated fragments of DNA, and some computers are better than others at doing it, and the cost can vary significantly between labs. Why do we do this if only looking for abnormal chromosome morphology and count instead of doing more traditional, presumably cheaper karyotyping?
Well, what I did say is that we count the chromosomes, but that's basically the purpose of the PGS. What I didn't say that in addition to counting the chromosomes, we also look for more subtle abnormalities in the chromosomes. So, for example, there's a condition called a deletion where a piece of DNA is missing. So the number of chromosomes is correct, but a part of the DNA is missing, and depending on how big that part is, that can actually lead to an abnormal embryo. So we look at there's deletions, there's duplication where a piece of DNA is duplicated, again can cause abnormalities, inversions where the part of the DNA strand is reversed. So any kind of chromosome breaks we can identify. So it's definitely more accurate and more helpful than doing just a typical karyotype.
All right, perfect. Thank you so much again for answering this question. There's another one, okay? So I've heard PGTA used to determine chromosomal normality. Can you please explain the distinction between PGD, PGS, PGTA, and any others we should know?
Yes, well, I think the terms can sometimes be confusing. But essentially, we talk about two categories, PGS and PGD. And then they come out. The new nomenclature is PGTA and PGTM. The difference between the two is the PGS is what I described. That's what we usually do. We do it, as I said, for IVF when there's an older person who we worry that they don't have any normal embryos. And it's exactly the technology that I explained. The PGD is a whole different process, a whole different animal, because the PGD, and by the way, stands for pre-implantation genetic diagnosis, is a procedure by which you actually identify what we call a single gene defect. So cystic fibrosis, muscular dystrophy, these are genes that actually abnormal gene that can cause disease in the child. And the PGD basically allows you to identify those embryos that carry that particular abnormal gene. It's a different procedure. It's more complex, more expensive. In order to do the PGD, you basically have to characterize, you have to identify that specific genetic defect, which means that you have to take samples from different family members and try to identify the particular mutation in the gene. And then once you've done that, you create what's called a probe. And a probe is like an antigen that will, or antibody that will identify that particular mutation. And that way you can screen out those abnormal embryos. So I didn't really mention PGD because for most people, that's not really relevant. But of course, people come to do IVF when they have this kind of a genetic history in their family, and then we can do one or both to make sure we have a healthy embryo.
Okay, perfect. Thank you so much for explaining those to us as well. And there's a question right here. So, do you have any house experience with donor failure, immunology experience?
Well, as I said, when you have 75, 80% success, which means that 20, 25% of the time it doesn't work. It's not always clear. I think that as much as we rely on the PGS to tell us everything we want to know about the embryo, it's still lacking because there are other things other than the PGS results that determine the viability. But as I said, even with the PGS the way we do it today, we still get almost a double. The success rate is almost doubled compared to no PGS. But what happens when when the IVF doesn't work? This is true in general, whether it's a donor or a non-donor. Then you have to look at other factors, and immunology is one aspect, and there are some cases where for some reason the woman's immune system fights off the pregnancy. Now, interestingly, that was a concern when we first started doing egg donation, because they said, well, you're taking an egg from a different person, maybe the woman would reject the embryo. But that actually happens to be not at all true. In fact, we know, from studying the immune system in pregnancy, is that pregnancy is sort of a protected area of the immune system. And if you think about it, any pregnancy is essentially like a foreign body, because at least half of the embryo, the sperm part, is a foreign body. So the pregnancy has created, or the body has created, a system of protecting the pregnancy from the immune system. Now, having said that, of course, there are cases where the woman's immune system is overactive and would reject her embryos as well as the donor embryos. In those cases, of course, we try to identify ahead of time and we try to treat. So that's when I said that we do a review of the history. That's part of what we look at. If someone's done IVF and had great embryos and no success, either no pregnancy at all or miscarriages, we basically have to look at the immune system before we switch over to egg donation.
All right. Thank you so much again for your explanation. Okay, and one more question. So do you offer any live birth guarantee programs?
Yes, we do. Yes, we do. I mean, we're very confident in our success. Mm-hmm. Of course, there are certain restrictions, such as the sperm. Mm-hmm. So we need to basically, the sperm has to meet certain criteria for us to say, okay, we'll do as many cycles as it takes to have a live birth. But we do offer that as well.
Okay, and how about the age limit when it comes to live birth guarantee program? Do you have any?
Well, interestingly, and I didn't emphasize that enough, that the ovaries age, and as I said, women that is in her late 30s, early 40s, we start to see a very quick decline in mm-hmm. fertility, and that's mostly has to do with the egg quality and ovarian function and egg quality. Interestingly, the uterus doesn't age very much. Even women who are in menopause, and we have actually quite a bit of experience with women who are in menopause, by just giving the proper hormones for a very short period of time, you can make the uterus as receptive as it was for someone who's 30. Mm-hmm. So there's not really much of a restriction as far as age and uterine function. So yeah, there's no, the guarantee program actually doesn't really have much to do with the age of the woman.
Okay, perfect. Thank you so much for clarifying this. I know you have said that costs we should definitely check. However, could you tell us if there is like a cost difference between fresh versus frozen?
Yes. So basically what I showed there is the full cycle fresh, split cycle fresh, and frozen eggs. And basically the full cycle is the most expensive, the split cycle is in between, and the frozen egg, one batch, is the least expensive.
Okay. Thank you so much again for answering this. You have said that there is no limit, right? Just to confirm, there is a question from the patient.
Yes.
Perfect.
There is
No,
there is no age limit. As long as you're healthy, as long as you understand all the implications of having a child, no, I don't have any age limits.
perfect. Thank you for clarifying this once again. And so, how many attempts with own embryos would you recommend before using a donated embryo? I am 35 to fight own cycles with low embryo numbers both time and not with good quality embryos.
Yeah, that's a really good question. Um, because I think, again, regardless of age, it sounds as if there is an issue with ovarian function, ovarian reserve, which translates into fewer eggs, probably poor egg quality. So my feeling, again, I'm a very big proponent of PGS, is even in those cases where you have low embryo numbers, to consider doing, at the very least, blastocyst culture, but also possibly PGS. Because what we find that in most of these failed cycles, the reason the cycle failed because the embryos were not normal to begin with. So those embryos had no chance of success from the start. So I think if you've done 2 cycles and you have no normal embryos, then I think the decision, I mean, it's never easy, but it's easier to say, okay, well, I did the best I could. If on the other hand, you do the transfer with day 3 embryos, where you can't really tell the difference between good and bad embryos, then it's hard to tell. It's really hard to tell. I think from the early days of IVF, and I was involved in some of those studies from the very early days, but we said, okay, how many attempts is reasonable to do? Because people are going through a cycle after cycle after cycle with no success, and it's exhausting and it's expensive and it's just physically and mentally, and it's just difficult. So we worked actually with, I was at Yale at the time, we worked with somebody from the math department and came up with this sort of formula that he took all the data and put it together. And what we found, and this was 20 years ago, and it's still true today, is basically that 95% of the success we get within 3 attempts. Which means that if you've done 3 attempts and it didn't work, unless you can find a really clear explanation and you can change it, then you shouldn't do any more treatments, because then you get to a point where you have to weigh all that goes into the treatment versus what you get out, and it's hard to justify putting all the effort into IVF when you know that your chances are 1%, 2%, 3%. So again, I mean, if you're 35 and you've done IVF, maybe it's never 0 chance, but if the chances are really low in the single digits, I think that's a time to consider changing something, and maybe in this case would be the eggs.
Perfect. Thank you so much again for your question and your answer to it. Okay, there's another question right here. I'll be using an egg donor. If sperm quality has been tested and is shown to be good for my husband, does his age make a difference like that of a woman? Would frozen sperm from a past IVF cycle from 7 years ago be better to use if the man is in his early 60s?
Yes, that's a very good question. So this is well, one of the differences, of course, many differences between men and women, but as far as fertility is concerned, the big difference between men and women is that women are born with all their eggs. So they don't make any new eggs. Essentially, by the age of 50, most women run out of eggs and go into menopause. For about 10 years before menopause, the eggs that remain are not the best eggs. There are fewer eggs that remain, that they're not the good quality eggs. Men, on the other hand, continue to make sperm forever. Actually, in fact, they've done a study where they looked at sperm counts for men that came in with their wives in labor, and they actually took them and did the sperm counts, and then they took their dads and did sperm counts, and they found there's no difference. So in other words, the sperm counts, the sperm profile, the count, the motility, the morphology of the sperm, the way they look, doesn't change with age. The fertility potential of the sperm is it's a different question, and that's still being studied, right? So, for example, there is sort of some concern about the fact that older dads have a higher incidence of children with autism, for example. So there's more subtle things that are not so easy to determine that are a result of an older dads as opposed to older moms. Because the older moms, basically the genetic defects that we found are basically chromosomal mismatch. Down syndrome is a perfect example. In men, it's not that. So it's basically more the quality of the DNA. These are things that are much more difficult to quantify. And we don't really have any good tests for that. There's some tests to looking at how intact the DNA is. And there's some studies that show there's maybe a slightly higher risk of cancer for children of older dads and things like that. But the data is very, it's inconclusive at best. Now, specifically to your question, if you have sperm that's 7 years younger than you are today, I would use it. Because if it was frozen properly and stored properly, that sperm probably has better fertility potential than the sperm today.
Okay, perfect. Thank you so much again for answering this question. Okay, there's another one right here. So do you also offer embryo donation adoption program in your clinic? So you have mentioned this, but
yes. So the embryo adoption is very attractive for some people because those are embryos that basically from couples who have been through IVF, often with egg donor. Often they ended up with way more embryos than they needed. And then they completed their family and have some embryos. And then they're giving a choice of either destroying the embryos or donating to another couple. The way it is, unfortunately, is that most couples that have extra embryos don't donate them to other couples. And, it's understandable because basically it's having full siblings that are carried and are somebody else's children. But we do offer that, and occasionally we have people who have donated their embryos. So it's something, if something you're interested in, definitely talk to us and we can sort of keep you on the list. And just keep in mind that they're much more difficult to come by. And when you do, you don't always have as much information as you want on those donors. For example, if it's an egg donor and a husband's sperm that created those embryos, you can definitely have the profile of the donor, and you gather information on the husband that will be protecting their anonymity. So the answer is yes, we do it. We do it anonymously. In other words, the donating couple doesn't really have any say to who the embryos go to, and you don't have any specific information about the donating couple. But yes, we do.
All right. Perfect. Thank you so much for confirming this. We now have two similar questions. So is the fresh eggs more successful than frozen? And the other one is there a difference in success or recommendation to using fresh versus frozen donor eggs? This might be an issue because of my unusual mixed background race.
Well, the thing about frozen eggs compared to fresh eggs is something that's continues to evolve. I would say that right now, frozen eggs are almost as good as fresh eggs. There's a small difference in success, but I don't think that difference is significant enough. As I said, I mean, you have to have a reason to use frozen eggs, whether it's financial reason, whether you don't want to create too many embryos. So I don't think the difference in success should be something that should deter you from using frozen eggs. Again, I'm not sure what that means if you have an unusual mixed background race, it really is and I think it's really about finding the right donor. And it's true that if you accept frozen eggs as well, that definitely broadens your choices. So yeah, so if you can find the donor that you like and she only has frozen eggs, definitely you can use her. But again, I think less and less we worry about the difference in success between fresh and frozen eggs.
Okay, thank you so much again for clarifying this. And next question is, can I use a member of the family to be my donor?
Yes, you can. So essentially, we have people that come with their own donors. Not very often. If you just think about it, mostly if these are women who are a little bit older, so usually their sisters are older or at an age where their egg quality is not so good. Some of them come with nieces or other family members. The answer is yes. You can definitely bring a family member. Um, the family member may not fit the criteria that we have. For example, many of the known donors, many of the people who bring donors, those donors are a little bit older than what we would normally accept. But we will test them exactly the same way as we would test our donors. And of course, it's even more important when you're using a family member to have a good legal contract with the donor.
Of course. Okay, perfect. Thank you so much. We will be slowly finishing. There are like few questions left. If we will have some
Sure.
questions that cannot be answered tonight, then of course we will forward them to you, Dr. Lavi, and your team. I'm sure you will be able to get back to the patients as well, right? But we do
My
have
pleasure. Yes.
exactly. We do have a few minutes, so let's get to the next one. You say we don't have a good way to separate male female sperm. But I've heard of microsorting.
Yes. So, we were part of that study of the company was called Microsort, and they came up with a innovative way of sorting male and female sperm. Actually, the sorting sperm has been an area of interest for me for many, many years. And of course, as I'm sure you know, there's a lot in the history books about trying to affect the chances of having a boy or a girl. Uh, None of the methods that were traditionally, as far as the timing of intercourse, position, diet, all these other things, none of them work. Uh, the company, the Microsort, came out with a new way of sorting sperm, and it's basically it uses what's called a cell sorter. It's actually an instrument that allows you to sort cells uh, based on certain characteristics, like size, for example. So we know for in the case of sperm that the male sperm is slightly larger, slightly heavier than the female sperm. So you put it through that machine. It's called a flow cytometer, and that sort of pushes the sperm one way or the other. A few problems with that. Number one, the company, after a few years of trials, could not get approval by the FDA in the U.S. So essentially, the process in the U.S. is not legal. And I'm not 100% sure why that happened, but I mean, there was some concern about safety, and basically they shut down their operations in the US. Now, interestingly, if you look at their results, they were much better at sorting female sperm than male sperm. So and we actually, years ago, we used to combine the gender selection IVF with sperm sorting because, of course, it makes sense that you put it through the sorter and then you fertilize the eggs. You can have a higher ratio of the sex that you want. Interestingly, their success with females was much higher than with males. So if you did the sperm sorting to have a girl, you'd have about 90% girl sperm and 10% male sperm. And with the male, it was not so good. It was maybe 70%, a little bit better than nature. But in any event, that's all sort of right now a non-issue because we cannot legally do it in the US.
All right, perfect. Thank you so much again for yet another question answered. And let's get to the next one. Okay, sorry, here it is. What do you do with the embryos of the other gender that are not used when a couple asks for gender selection?
Well, of course, it's a great question, and this is something we discuss immediately with couples that come here specifically for gender selection. Because in the first consultation, I always tell them that again we usually it's 50-50. Especially if we have lots of eggs and embryos like we do with donors. So it may not be exactly 50-50, but it's almost certain that you'll have embryos of both genders. But you have to consider the following. Number one, you have to consider the possibility that you will not have a gender that you want. That's happened. I've had a few cases like that. The couple came in and wanted to have a boy, and they had all girl embryos, and vice versa. The other thing that you have to think about and consider before you put yourself through it is that you're going to have basically genetically normal embryos that you're not going to want. So you have to think if you're comfortable destroying those embryos, if you want to donate them. So the thing is, you need to get all that information sorted in your head up front before you start, because you don't want to be in that situation later and say, oh my God, what happened? I have all these embryos, I don't know what to do with them. So we will talk about it, make sure that you're comfortable before we move forward with that.
All right, fantastic. Thanks so much again for this question and your help with it. And the next question is right here. In the past IVF cycles, if I've had 3 or less eggs retrieved and the result is only one embryo, would PGS testing be recommended even on one embryo? I understand PGS testing is done on frozen embryos, not fresh.
Well, the PGS actually is best done on fresh embryos. In other words, the embryo grows to the blastocyst stage. It has about 200 cells. It's already differentiated, so you can tell the difference between the part of the embryo that would be the baby and the placenta. And then you take a few cells from the placental side, and then you freeze the embryo. That's the standard way of doing it. That's the recommended way of doing it. And if you do it that way, you will not affect the viability or the success of the procedure. Now, we come across cases where people already have embryos frozen that have not been PGS tested, and they ask, well, can we test those embryos? The answer is yes. Is it recommended? Not so much, because in order to do that, you need to do the following. You have to take those frozen embryos, you have to thaw them, then you have to grow them a little bit and then extract the cells and then freeze them again. And then when you get the results, you thaw them again to do the transfer. So, of course, this can't be good for the embryo. And we do have some experience with it, and we've had good success with it overall, but you are putting the embryo through a lot, and you have to think, twice before you take frozen embryos and apply the PGS.
All right, perfect. Thank you so much. We still have a few minutes left, okay? So let's get to them as much as we can. And, well, we will get back to you with some other ones as well. So do you do HLA-KIR matching for donors and recipients?
Usually not, actually, almost never. I don't remember the last time we did. It's theoretically possible that there's going to be necessary especially for someone who's had repeated miscarriages that related to HLA. So of course, the answer is we can do it, but again, depends very much on your history. If that's something that's in your history and it's clearly a reason that you haven't been able to carry a pregnancy, so because of a HLA similarity between you and your husband, we can definitely test the donor.
Okay, fantastic. Thank you so much again for that question and your help with it. And there's another one, short one. So, do fibroids outside the uterus affect implantation?
Well, again, that's a topic for another talk, but it's generally speaking, the evaluation prior to doing IVF includes a very careful evaluation of the uterus. Fibroids can be a factor. It depends on their location and depends on their size. So technically speaking, if the fibroid is in or growing into the cavity, if it distorts the uterine cavity, then there is a possibility it will affect the implantation, and we recommend that it be removed. If the fibroid is going outside of the uterus, either in the wall of the uterus or towards the other side, then unless it's really large, it probably doesn't have an impact. So this is something that needs to be evaluated individually, again, based on the history, based on the findings, and then decide if the fibroid is a factor or could be a factor if it needs to be removed.
Perfect. Thank you so much once again. And another question is, would shipping frozen sperm from as far as from South Africa to US or Europe be possible or recommended?
Yes, I mean, it doesn't really matter where the sperm comes from, as long as it goes through a proper freezing. Just remember that the eggs, embryos, sperm are frozen in liquid nitrogen. So as long as they're held at the right temperature and transported appropriately, it doesn't matter how far they have to come. We look a little bit differently at transporting embryos and sperm. We look at embryos as basically irreplaceable in a sense, or at least that it took a lot of work to create them. So those usually are transported with a courier, with a person who goes and personally picks up the tank and gets on the plane and delivers the embryos. With sperm, it depends. We often do it through FedEx or DHL. I mean, they have a program to do that. So yeah, but the distance doesn't really matter as long as it's done properly.
Fantastic. Thank you so much once again for this. There are like 3 questions left, quite short ones, so I believe we will be able to finish. So let's go to this one. Does my husband have to sign the paperwork for embryo donation too?
I would say yes if you're married. But again, it's something you need to check with your attorney. As long as you are pregnant, and whether the sperm is his sperm or not his sperm, because that's really the difference. I think that technically, for most part, from my understanding, they would still be considered the legal father and have all the responsibilities to go with that. So yes, I would think so.
All right. Thank you so much for confirming this. And what generally does immunology testing involve?
Well, immunological testing is mostly blood work, and we have a panel uh, that basically looks at all the different immune factors that can cause women to miscarry or not get pregnant. We call it the thrombophilia evaluation. It looks at basically clotting factors and antibodies that can be in the way. So that's a pretty simple test. The interpretation is sometimes difficult. But again, you have to know the person, you have to look at their history, and it has to correlate with the results of the test.
Okay. Thank you again for this. And as I mentioned, now it will be our last question for today. So any questions? There are no questions. However, if you will have any, just remember to use the link I have sent. You will be able to ask your question directly to Dr. Levy and his team. And the question is, if you decide to donate leftover embryos, is that always anonymous, or are there options for the children to have contact at age 18? And can you prescribe your preference for those parents who receive your leftover embryos?
Well, it's one of those things that whatever it works for you. I mean, I most of the embryo donations we've done were anonymous. Of course, we have people that say, "Well, I have a friend who wants my embryos." That's perfectly fine. And then there's everything in between. So if you want to donate your embryos and you have certain conditions, for example, we have someone now who wants to donate her embryos and wants to do it not it basically wants to know who the embryos go to. So we're still waiting because many of the people that want the embryos prefer not to have that connection. So nothing is out of the question. It's just a matter of how realistic it is and exactly how you want to do it.
Okay. Thank you so much. As I mentioned, that was our last question for tonight. Thank you so much. That was definitely interesting and so informative. Lots of new things to find out for sure. So, Dr. Lavi, thank you so much for joining our initiative, Stronger Together initiative, and for your time. We are very happy to have you here with us tonight for sure. And someone is typing, so I just want to make sure that all has been answered. It looks like it, but really, it has been a pleasure to have you here. Are there any final words you would like to, anything that you would like to add?
Well, so first again, thank you, Carolyn, for organizing, and thank you all of you for being here. I think especially in these difficult times with the COVID, and we're sort of trying to look at the light at the end of the tunnel.
That's for
So
sure.
planning on good things. So if this is something that you're thinking of, something that you would like to do, I mean, it's not too soon to at least talk about it. So I'm more than happy to have a conversation, a consultation with you. And as I said, this is a very, very personal, intimate journey. So everyone comes from a different place. Everybody has different feelings, and it just has to be right for you. But before you can determine if it's right for you, I think you have to get a really good understanding how the whole thing works. And finally, it's again, if you're a couple, it's very important that you do it together. And you have to be on the same page. Interestingly, we find, of course, all different situations. Sometimes it's the woman who's not comfortable because it's not her eggs. But actually, I'd say that more often, even though the man actually uses his own sperm, sometimes they're not comfortable. So again, it's such a personal situation and it's such a personal journey that I think you need to think really hard. And if you're interested, we will try to give you enough information to make you make at least a good decision for yourself.
Perfect. Thank you so much. As you can see, there are plenty of thank yous from the patients right here. I just wanted you to see it. Thank you so much. Perfect.
Thank you for being here, and and I'll be happy to meet.
Perfect. Thank you.
Take
and
care.
Well, let's just remind everyone that we will have another IVF webinar in 15 minutes exactly. So stay tuned and join us, and we will tackle another topic. And you will have a chance to ask again your questions. So stay tuned with us. We will be sorry. We will be back tomorrow as well at 6 p.m. Again, Dr. Lavi, thank you so much, and well, have a lovely day. And well, I hope we will be able to do it sometime as well. Perfect. Thank you. Enjoy the day.
Bye-bye.
Bye.
Bye-bye.